Hello, my name is Dr. James Stone, and it's my pleasure to be here today with Dr. Oscar Sugar, Professor Emeritus of Neurologic Surgery at the University of Illinois, Chicago, and currently Clinical Professor of Neurologic Surgery at University of California in San Diego. Welcome, Dr. Sugar.
Thank you.
I thought we would run down your early childhood, early educational experiences, and take it up through graduate school, medical school, and get into it in that fashion if we could. Could you tell us a little bit about your early upbringing?
Yes. I was born in Washington, D.C. on the second floor of a building occupied on the first floor by a grocery store, which was owned and run by my parents. It was a home delivery. I'm the fourth of four children. And my life and the grocery store were entwined for about 20 years thereafter. We moved from time to time in the city of Washington, and I went to the public school system there, to the Western High School, one of the three unnamed high schools in Washington. There was also an Eastern and a Central High School to which my sisters went later. And the school system for children in Washington at that time was quite good, and the teachers were very easy to get along with, and consequently they allowed me to skip several grades from time to time, so that when I got to high school I had skipped 2 whole grades, and from then on I had the problem of being usually the youngest and smallest member of the school classes in which I went. I was not athletically inclined, and in place of football or any other team sport, I became a member of the what at that time was called the Washington, D.C. Cadet Corps, which was a high school ROTC, where I ultimately became a captain, which was a fairly good grade for a small youth. And went through the school system. The Western High School had a very good teacher group, including a biology teacher that I remember very well. Her name was Catherine Steinle, S-T-E-I-N-L-E, who found me a kindred soul that she could talk to about biological materials. And we used to go hunting animals and plants in the area around Washington. And she, I think, was the one who directed me in my ideas that I would like to be a scientist of some sort. On the other hand, there was the impetus from my own parents who felt that earning a living was a worthwhile thing, no matter how you did it, and consequently I helped in the grocery store from the time I was 13 until well into college. But both my family and my biology teacher felt that some sort of biological science would be the right place for me. My family didn't know much about biological sciences except for one called medicine, and they thought that maybe I would be a good doctor, and I was willing to go along with that. Anything was better than working in the grocery store at that time in my life anyway. So I got through with high school when I was 16, I think, and got a part-time scholarship at the Johns Hopkins University in Baltimore, which was possible because we had relatives in Baltimore. As a matter of fact, Baltimore was the place to which both of my parents independently came when they left Europe to settle in the United States. They met in Baltimore, but moved to Washington and married there. They had friends and relatives still in Baltimore. So I went to the Johns Hopkins undergraduate school. I didn't know much about it at that time. Johns Hopkins was a place well known already by that time in medicine, but it turns out that it had a very excellent undergraduate school, which I did well. And I finished the 4-year course and got my degree, but life was not completely without problems. One of them was it was difficult for me to get into medical school. And consequently, I went back to Washington, worked in the grocery store part-time, and became a graduate student at the Columbian College of the George Washington University in Washington, D.C., and finished some work I had started in zoology at Hopkins on the sympathetic nervous system of the black snake, a very erudite field that almost no one was interested in except me, and it enabled me to get a thesis and a degree in zoology at the graduate level. And with those two things under my belt, I thought that maybe now I would have a chance to go further into biology elsewhere.
Can I stop you right
Yes.
there? There's an interesting story you've told me of when you were an undergraduate student at Hopkins and one day decided you would go see some Dr. Dandy do some neurosurgery.
Oh, yes.
Could you tell us a little bit about that story?
Yes. The undergraduate school at Johns Hopkins is in a park-like setting, which is a very nice setting. The medical school and hospital were in a part of Baltimore which can only be described as rundown and somewhat lower class. So it was not frequent for people at the undergraduate school to get over to the medical school. It was all the way across town, and the transportation was not good. But one morning, I girded up my loins, so to speak, and went over and was allowed with a few other medical aspirants to go into the operating amphitheater where Dr. Dandy was then operating. And he was not very vocal to explain what was going on, but we got the impression that the patient he was operating on had a pituitary tumor, and the approach he used that time was one about which I knew nothing, and as a matter of fact, I didn't know much about it even later when I became a medical student, because it was unusual. That is, it was under the temporal lobe, which is a very unusual way for anyone to get to the pituitary gland even now. And he was having a hard time getting the temporal lobe out of the way so that he could work in his field, and tensions rose sufficiently, as I remember it, that he just got into such a huff that he said everybody should leave, and we all left. The skill of which he was so obviously a master was not shown on that particular day, but it made me think that if such a great man as Walter Dandy could have trouble operating, that maybe I could do the same sometime and have trouble operating, I suppose. But it was one of the few occasions when I got over to the medical school and the operating room over in Baltimore.
So I believe that brings us up to approximately 1935, after you've obtained your master's degree
Yes.
at George Washington.
A classmate of mine at Johns Hopkins named Albert Potts had similar academic success and what you might call sociological ill fortune of not being able to get in medical school. It was not too uncommon a fate for young Jewish men to have some difficulty getting into medical school, just the same way that there was some difficulty in California for people of Eastern origin from Asia. There is some residue of inability to get along with the white Caucasians who feel that they have an innate priority in getting into all kinds of schooling in California. So in all events, I did not get to medical school, and my friend, who is now Dr. Potts, was basically interested in biochemistry and went to the University of Chicago, and after finding a sympathetic ear among the people to whom he spoke, he became a graduate student in biochemistry, and he got in touch with me and said that he thought that the neurophysiology department there was very excellent, and suggested I consider coming there and perhaps become a basic scientist in physiology. So the sugar clan in the grocery business got money together, and I went off to Chicago, where I entered the physiology department as a graduate student in the midst of a series of lectures which had nothing to do with the nervous system at all, but with circulation. And I took anatomy and with the medical students. I took physiology with the medical students. And I got along very well with them and with my boss, whose name was Ralph Gerard. Gerard was an MD and PhD in neurophysiology, and a very widely versed person who enjoyed working with young people, who also enjoyed working with him. And he became my mentor and teacher and associate and boss, and ultimately my employer, because he was enormously well-read, but had some difficulty with French, and he was too busy to pick up a dictionary and look up all the words he didn't know. So I did abstracting of French physiology articles for him, and arranged them, typed them, and helped him in that regard. And in turn, he taught me a lot of neurophysiology and allowed me to assist him in operating on animal brains. And for some reasons which are not quite apparent to me, I developed some skill at this and was able to help him while keeping out of his way, which is a very nice thing for the senior surgeon of any group, to have someone who can help and yet not try to do the operation himself. In all events, it was possible for me to help, and he thought that perhaps I would make a good neurosurgeon someday, and he was willing to recommend me for that when the time came. But in the meantime, he set me to work on working in the spinal cord and brain of animals, and my thesis was on the spinal cord of the rat, and attempts which were being made then and are still being made to induce the neurons in the spinal cord to grow once they had been cut. I don't think that the success in this has gotten to the point yet where it's applicable to a human, but it still interests me and many other people, and I was glad to be involved in it.
I wonder if we could touch upon some of the other work going on that you helped with in Gerard's lab, the Horsley-Clark stereotactic frame with the concentric needle electrode and the evoked potentials and so forth.
Sure. At that time, the physiology department and its allies They were in the same building with pharmacology and with biochemistry. There was a great deal of interest in all of the nervous system at the University of Chicago. There was a man named Nathaniel Kleitman who was interested in brain waves and in sleep. He was one of the first people who showed that in a constant environment like the caves in Kentucky, a person who was young could readily adjust to any sort of change in day length. That is, instead of having 24-hour days, you could make 10 hours light and 8 hours dark. And young people in their teens and 20s could adjust to that very well, whereas he, who was then in his 40s, could not do that. He retained his old sleep and wake habits and still had a more or less 24-hour day, which is half sleep and half not sleep. But the young people didn't. He became very interested in sleep and in brain waves. And since I was younger than he was by a considerable amount, I became one of his subjects because the system at the University of Chicago was one of enormous cooperation between subdivisions in any department, and physiology was certainly one of those. So I had my brains waved, so to speak. At one time, they even had me sleep for a radio transmission that was on a science program, and little bursts of wakefulness and sleep were part of my life at that time. Dr. Gerard was interested in not only biochemistry of the surface or brain as a whole, but on the metabolism, blood supply, and chemistry of the depths of the brain. Cat brains were available a little bit more readily than dog brains because of the furor about working on animals at the University of Chicago, which has been a persisting thorn in the side of an investigator. And I learned how to establish a location of an electrode or injection apparatus in the different parts of the brain using the apparatus, which was made by Clark for Sir Victor Horsley many years before, and which was introduced largely through Dr. Gerard into the Chicago area. And that led to some interesting aspects on what happens to the functioning of the brain, including brain waves, when you deprive the brain of blood. And it was possible to show that the brain waves would disappear very quickly when the blood flow was interrupted. And if it wasn't interrupted too long, they would come back, and so would the function of the cat. You couldn't exactly apply that to a human being, but you could certainly tell whether or not the brain was damaged. Then we would fix the brains and cut them and examine them under the microscope. Dr. Gerard would also ask for pieces of different parts of the brain, which he would then work on with biochemistry in order to see what the enzyme systems did when they were deprived of blood and oxygen. And he made a number of interesting and useful studies, I think, on the intimate biochemistry of the physiology of the brain.
Mm-hmm. I believe one important contribution was showing that Ammon's horn is a susceptible region to anoxia.
That's right. And that was part of the ongoing study at the University of Chicago between the anatomy department and physiology department and the neurosurgeons, working with temporal lobe under Dr. Bucy and Dr. Kluver to show that seizures could be induced by damage to the temporal lobe, and Ammon's horn in particular. And it was really the location of the, you might call the competition for Penfield in Canada for the relationship between the hippocampus and the temporal lobe and psychomotor epilepsy. And this in turn led later to Dr. Percival Bailey, who was the chief neurosurgeon when I was there, led him to operate independently of Wilder Penfield for psychomotor epilepsy by working in the temporal lobe.
I understand Percival Bailey had his neurosurgery program at University of Chicago while you were a graduate student at University of Chicago.
That's right.
And I believe Dr. Cloward was one of the residents. And could you explain your interaction
Yes.
with that group and your recollections of that group?
Dr. Bailey had come to the University of Chicago to be its neurosurgeon. Over the public acknowledgement from Dr. Cushing that Dr. Bailey would never be a neurosurgeon because he lacked that which the master neurosurgeon thought necessary, impartial, one-way street into neurosurgery. And since Dr. Cushing and Dr. Bailey didn't always agree on what they were doing, it was a little difficult for Dr. Bailey to get started. And especially it was difficult because he became ill not too long after he got to the University of Chicago. And a young upstart from Iowa named Bucy was his resident, and he really took over the service while Dr. Bailey was recovering from a mysterious illness, which may have been encephalitis. It's not very clear to me yet. But in all events, Dr. Bailey did establish a neurosurgical program. Dr. Bucy was his next in command, and their residency training program was excellent. One of their applicants and residents was Ralph Cloward, who originally was from Hawaii and who went back to Hawaii after he got finished with his training. They didn't have too much help in their animal lab, and I was asked if I would like to go over and help. I keep repeating the emphasis on the interaction between the various people interested in the nervous system at the University of Chicago, whether it was for humans or animals or biochemistry. They all formed a large group of interacting and very mutually helpful people. So Cloward needed some help, and Dr. Bucy and Dr. Bailey asked Dr. Gerard if they had anybody that they could ship over to help Dr. Cloward, and I was selected and went over and became Cloward's first assistant in the operations on the monkeys, which he was doing. And
what was he doing?
He was removing parts of the temporal lobe to have the animals survive and then watch the behavior to see if the animals behaved as they were said to. That is, if you took out one temporal lobe, the animals seemed to be pretty much all right, but if you took out both temporal lobes, the animals became misguided, unfriendly, and had various personality defects involving sex, which led to some interesting experiments.
Is it, I believe Heinrich Kluver trained the monkeys,
Yes.
and then he examined the monkeys
That's right.
Afterward.
That's right. The monkeys could be trained to select foods and other things, and if their temporal lobes were damaged enough, they would lose this ability, and this led to the syndrome of the temporal lobe that Bucy and Kluver so wisely studied.
Well, after the graduate experience, then I believe you went back to medical school.
Yes, that's right. I was accepted at the George Washington University in their School of Medicine shortly after my brother had been accepted the year before. And so he got out before I did, which was fine. And it was an interesting experience to me and to the people in the school, because I had already had the typical medical school training in neuroanatomy, neurophysiology, and gross anatomy, and microscopic anatomy. And when those subjects came up in the first 2 years of medical school, the powers that be said that I could act as an instructor instead of sitting down and repeating the same work over and over and over again. So I became a teacher at that time and got to know the neurologists and neurosurgeons there, including the chief of the neurology department, who was Walter Freeman, and the chief of neurosurgery, which at that time was a subdivision of general surgery under James Watts. And that was another impetus for me to continue on in my interest in the nervous system and to learn a lot of what I know from both of those gentlemen.
Were you on the surgical service under Watts?
Only as a medical student. They used to have meetings every once in a while, which I sneaked into whenever I could, but I did not have any intimate neurosurgical experience with Dr. Watts. I did see more clinical neurology with Dr. Freeman, and it was because of my interest in neurology with him that I applied to the St. Elizabeth's Hospital, which is the hospital for the what are called insane right outside of Washington, D.C., and it was one of the 2 hospitals I applied to for internship and was accepted at. But I went to the University of Illinois instead because of my feeling that neurosurgery was a better home for me, and it was not available at St. Elizabeth's Hospital, but was available at the University of Illinois.
So you began your internship at University of Illinois roughly, is that 1941 or 42?
It was in February of 1942. I was to have graduated in June of 1942, but the entry of the United States into the war accelerated the schooling process, so I got out in February instead of June, and applied at St. Elizabeth's and also at the University of Illinois Hospital, which was called at that time the Research and Educational Hospital. I applied there because I knew that that's where Dr. Percival Bailey was going to go to when he left the University of Chicago. And so I applied and was accepted as an intern. And they didn't know exactly what to do with me because of this accelerated program. So the first rotation they put me on was in neurology and neurosurgery, which were at that time under the headship of Dr. Eric Oldberg as head of neurology and neurosurgery. At that time, also, there was a well-graduated residency training program with a senior resident and a junior resident, and there actually were 3 years and soon became 4-year residency, and I was an intern. So I was really below the interest of the heads of the department at that time. Most of my experiences were with the residency staff. But it was very enjoyable to me and very interesting, and I met up with Dr. Bailey and Dr. Bucy again. And later on, after my rotations in the other fields of medicine and surgery were over with, I came back and worked in Dr. Oldberg's department again. He still was at heights above the intern. One didn't get to talk to him very much. You talked to the resident, and the resident talked to God, but this was as close to that as I could get. On the other hand, when he was off service, and particularly on Saturdays when Dr. Bailey made rounds, Dr. Bailey I had met at the University of Chicago, and he knew who I was and that I had worked with Cloward, and he was much more approachable. And it was an interesting experience for me to see how two different senior neurosurgeons worked. Dr. Oldberg was more meticulous and less experimental. Dr. Bailey was willing to try new things. He was very inventive and was willing to take chances that Dr. Oldberg would not take. But it's a very fruitful experience for me.
What were some of the duties of the intern on neurology neurosurgery at that time that you recall?
Oh, well, we were responsible for an examination of the patient and a history. And we were also responsible for doing the blood count, urinalysis, and drawing bloods, and what typically was a job of any intern in those days.
You told me a story about when they had difficulty with a patient with blood loss, the intern would be required to come up under the drapes and try to start an IV, or
yes.
draw blood from family members or something to that effect?
Sure. There was no such thing as a functional blood bank. And one of the jobs of the intern was to convince the family that there probably was not going to be very much trouble, but if there was a blood loss, we would have to get blood from a relative. And consequently, it was our responsibility to see to it the relatives came in and blood was matched with the patient's blood, and then any family member who had a blood type like that of the patient was required to come and sit in the waiting room while the operation was going on, so that if blood was going to be necessary, the intern could draw the blood from the donor and administer it while the patient was under the drapes. That was a hectic time because transfusions were considered to be quite dangerous for the patient, primarily. And Dr. Oldberg was brought up by Dr. Cushing to use transfusions as rarely as possible. And it wasn't enough that the patient's blood pressure might drop from normal levels to 80 or 70 during some episode of bleeding. That was not the time to give the transfusion. Fluids were given, the blooding was stopped, and then the patient was allowed to recover to an almost normal blood pressure. That's not the time to give the transfusion. It was the next time when the patient bled again and there was fear that he might bleed excessively. And that was the time that the blood had to be drawn into a citrated container and quickly brought to the operating room from the patient's waiting room, which was on the same floor at the time of the operation, and started and pumped in as vigorously as possible, and with someone, the anesthesiologist or someone taking the blood pressure, and when the blood pressure reached a reasonable amount and all the blood that was drawn was given, then the operation might continue or might not, depending on the psychological trauma to the surgeon at the time of whether or not he wanted to go through that again. It was not an easy thing to do.
I believe after your internship, Dr. Bailey was instrumental in giving a recommendation to Dr. Oldberg to take you into the neurosurgical program.
That's true. Dr. Bailey had, at that time, the neuropathology laboratory. You'll recall that he had been Cushing's neuropathologist before Cushing had his own neuropathologist whom he trained. And people were sent to Dr. Bailey particularly from the western half of the United States to learn neuropathology. And the residents who finished elsewhere would come, or they might come during their residency training program. And they would be given slides and lectures and assist Dr. Bailey at autopsies. And it was really an ongoing center for neuropathology for the western half of the United States. And I got involved in that because I knew more neuroanatomy than most of the residents did, and had done staining work when I was with the animals and the spinal cords, and had gotten to know Dr. Bailey a little bit better and to talk with him on a number of occasions. And actually, later on, I substituted for Dr. Bailey when brain cutting was to be done on autopsy cases. So Dr. Bailey and his residents, who were in neuropathology, had asked me to help with the translations for articles for the residents who knew only as much foreign language as they had to know in order to get their degree. So I would read articles for them, so they got to know me and to tolerate me. And so I told Dr. Bailey that I was interested in the residency training program, but that I never had a chance to speak to Dr. Oldberg very much because he was always busy. So he went to talk to Dr. Oldberg, and Dr. Oldberg agreed that maybe I could be trusted to be a resident, but because he didn't know me personally very well, he didn't get many reports from me directly, he suggested that I come to the St. Luke's Hospital, which at that time was his private practice hospital, and to which his residents were taken for their usually their first year. There, the first year resident did everything except operate on the patient. He examined and wrote and ordered things and did the chemistries and took care of the patients and literally lived in the hospital with him. And he thought that that way he would get to know me better and to teach me what it would be like to be one of his residents. So we agreed that I would start the next July, and towards the end of June, I took my radio phonograph with the classical records and the books and shipped them over to the St. Luke's Hospital, and was all ready for July 1 to start when I received a missive in the mail from His Majesty's Army saying, greetings, we would like you to come work with us for a while. So I had to not be a resident for a while, and it luckily didn't sour Dr. Oldberg. He felt that if I was not going to be there, at least it was for a good reason. So ultimately I was able to come back and be his resident, but at the University of Illinois.
Can you tell us a bit about the military experience, especially the neurologically oriented exposure you had there?
Yes. Most doctors who were taken into the Army were sent to a training center, one place or another, to be indoctrinated on how to be an Army doctor. Somehow or the other, somebody found out that I had a PhD in neurophysiology, that I had worked in electroencephalography, and that I also knew a little bit of neurosurgery. So they sent me for a very brief time to Texas for indoctrination, which largely was how to put on a uniform and how to march, which I already had experience with as a cadet in the high school. And then, without any further ado at all, they shipped me to Santa Ana Army Air Base, which was a place for training air crew, pilots and navigators. The principal usefulness I had for the Army was to teach the air crew how to recognize the fact that they were in trouble for lack of oxygen and what to do about it, and the necessity for them to wear oxygen masks with oxygen running in order that they not lose their judgment or lose consciousness. And in order to teach people that, low pressure chambers were invented again, only not just for one person, but for 16 or 20 people at a time, with 16 or 20 masks and a technician from the Army to run the mechanics of the machinery, and what was called aviation physiologist, which was what my military occupational specialty was, to sit in the same room with all the cadets and to teach them by example, using one of the, quotes, volunteers, what to do about lack of oxygen by evacuating the low pressure chamber to a low oxygen level which would be comparable from 10 to 20,000 feet in the air, and to show on the basis of a volunteer how without oxygen the person would turn blue and become disoriented and then briefly become unconscious.
Do you have EEGs running on these recruits at that time?
They were not basically done on all the people who were there. We did get volunteers to do that, and it became evident that humans were like cats. That is, they didn't tolerate oxygen lack very much. Their brain waves would get larger and then gradually disappear, and then disappear for good in the cats, but in the humans we never let them do that. So we had quite a bit of experience with anoxia. That was really what I was supposed to be there for. And the EEG apparatus was brought in later on when the air crews no longer were needed. And the hospital branch that I was working with became a center for rehabilitating pilots and other air crew after they had been flying. They had various psychological impairments from their experiences, and the hospital in Santa Ana became a rehabilitation center. And people who had been in combat or in preparation for combat and who had psychological and psychiatric problems were put together in the ward, and I was made the chief of the ward under a certified psychiatrist named Oldberg. So my job then was to take care of the air crew, male and female, who were in trouble from their reactions to combat, and also to their reactions to not being in combat, when they wanted to go or when they were afraid they would go and didn't want to go. We had a selection of people from the artistic movie colony who had joined the armed services, thinking that they would be entertainers or somehow do their stint without having to really be very much in the way of Army personnel. And when they found that they would have to drill like anybody else and not become officers right away, they had various problems psychologically, which I think many of them would have had anyway, but it was certainly accelerated by their being in the armed services. And from the psychiatric standpoint, the chief psychiatrist in our hospital felt that they would really be much better off if they were out of the armed services, but that became a public relations nightmare when it became obvious that people who had joined from the movie colony and who couldn't tolerate the social difficulties of living in a communal area and having a military environment, this was simply unbearable, and it wasn't just voluntary on their part. I mean, they wanted to get out of the Army. That was voluntary, of course, but their illness was real, and we had a lot of difficulty with the higher authorities because of the public relations standpoint of letting such misfits who could do very well in civilian life but couldn't do well in Army life.
You feel the psychiatric experience helped your neurosurgical career later?
Well, I think it did. In the first place, it gave me credit for 1 year of psychiatric training, which I never had to use, but the board accepted it as part of my training when it came time to be in touch with the board of neurological surgery. And I think it was very valuable to me, perhaps in making me more tolerant than I might otherwise have been to people who had difficulty accepting the fact that they had neurological ailments, and their relatives too. So it, in some respects, I guess, made me a kindly old man before I was as old as I am now.
Well, then I think it takes us up through 1946, and you're coming back
Yes.
into the residency.
That's right. I had acquired enough points to enable me to leave the armed service, especially since the war in Europe was over and the war in Japan was just about over. And the Army said, okay, you can go back, do whatever you want to do. If you will promote you to be a major if you'd like to stay in the Army, but I said I didn't care for that. Captain was good enough for me. And Dr. Oldberg agreed to take me back on, and I became his resident and had achieved enough ancillary credits in neurosurgery so that I only had to go from April of 46 to September of 48 with the consent of the board. So I became Dr. Oldberg's junior resident and his senior resident, and there was enough time to work in the basement laboratory in neurophysiology, principally under Dr. Bailey, and it turned out to be a wonderful way of continuing on.
Can you describe some of the work going on in the basement primate lab at the NPI at that time?
Yes. There was a great deal of interest on Dr. Bailey and Dr. Bucy's part and the part of the anatomist from the Neuroanatomy department, Gerard from Bonin, in the different parcellations of the brain. It had been known for a long time that different parts of the brain had different functions, and the parts which were removed might leave a lasting deficit. Other parts seemed to be removable without causing too much trouble. And the intense cooperation between anatomy and physiology and neurosurgery, which was present at the University of Chicago, was carried over to the University of Illinois when Bucy and Bailey came over. And it was possible for Dr. Bailey and Dr. Bucy to set up work in the field of the chimpanzee and the monkey of trying to see what parts of the brain were connected to other parts. That has a long history in neuroanatomy, and the contribution that was made at the University of Illinois was to do the same thing from a physiological standpoint. It was found that one could stimulate small groups of neurons by laying on little pledgets of cotton or paper containing strychnine, which would stimulate the nerve cells underneath, and then one could explore the rest of the brain either on the surface or by putting needles into the depth to see where the spike waves which were induced in the brain by strychnine would be carried. And that way we were able to map out the connections from one part of the brain to another in considerable detail. And in the course of that work, which was started by Dr. Bailey and Dr. McCulloch, but was transferred to the juniors as time went on, with supervision from Dr. Bailey in particular, we were able to make a number of findings which were either preceded anatomical connections or confirmed anatomical connections. And in so doing, we were fortunate enough to hit upon the idea that maybe if we changed and used electrical currents, we could modify the type of information sent to the brain cells so that we could pick up different types of connections. So we found, for instance, that in the frontal eye motor cortex, the place commonly called Area 6, or one of the more anterior eye movement areas, where it was known for a long time that electrical stimulation would move the eyes to one side or another. It was possible to find that if you change the current characteristics from, we'll say, 60 cycle to 200 or 300, that parts of the brain would behave in ways which were not known before. For instance, from the frontal eye field, it was commonly said the eyes would turn one side or the other. And we found that if you change the electrical characteristics of the stimulation, that you could also make the eyes go up and down. And it's obvious that people's eyes have been moving up and down for a long time before it was discovered that it's the same general place, but you had to coax it to do so by different methods. And we were also able to locate parts of the brain which up till then it had not been certain that they had a movement function. That is, the usual motor cortex in the region of the central sulcus on the side of the brain in the human being was well known. It was well known in animals, of course. It was not well known that there were other parts of the brain from which movements could be elicited by electrical stimulation. These so-called second motor cortices proved to be of great interest to not only to us, but to Dr. Penfield and his group. There is a frontal motor cortex on the medial side of the frontal lobe. There's another one which is buried in the Sylvian fissure, from which movements can be elicited, and the pathways between these were mapped out with the strychnine technique. So we had quite a life down in the basement laboratories. The animals were well treated, they were kept anesthetized, and we would use them until literally there was nothing left to look for. We were at no time cruel. I remember very distinctly being accused in some of the literature from the anti-vivisectionists of poking electrical needles into the brain of animals without any mention of the fact that they were anesthetized and never felt anything and were never allowed to awaken so that they would never really suffer.
Mm-hmm. Mm-hmm. How about if we move on to some of the clinical material at that time? I understand you were very interested in angiography, especially vertebral angiography, and the disclosure and treatment of vascular anomalies. Can you tell me a little bit about how that interest started and some of the contributions there?
Sure. Angiography to get a picture on an X-ray of the blood vessels of the brain really started with Egas Moniz, the Portuguese scientist, neurologist, physiologist, who himself was not a neurosurgeon, but who felt that this was an investigation which ought to be made, and he did so. The concepts which he wrote about, first in French and then later in other languages as well, were taken up by the same Walter Freeman who was involved with the frontal leucotomies and brought to the United States and then to Boston. And Dr. Bailey became interested in angiography because it gave him a way of finding out what the blood supply to a projected operative region was. And he really induced the residents to make possible percutaneous carotid angiograms. Dr. Oldberg was not particularly interested in this field. Neither, as you probably well know, was Dr. Walter Dandy or Dr. Cushing. But Dr. Bailey was interested and induced the residents to do angiograms because he felt that he could determine the size and shape of a tumor and the vascularity of a tumor before operating. Dr. Oldberg was not convinced that this was really a great addition, but he was, as he was in many things, very tolerant at times. And one of the things he allowed Dr. Bailey to do was to push forward with the angiograms. And the resident staff got pretty expert and taught one another to do percutaneous carotid angiograms. But every once in a while, in some thick-necked person or due to a thyroid gland that was out of position, the resident's needle would inject the material into a blood vessel, and lo and behold, it proved to be accidental filling of the vertebral artery. And with his customary facility for nudging other people, Dr. Bailey then said, well, if you can do this accidentally, you ought to be able to do it on purpose. So the senior residents became interested in this project, and soon all the senior residents for the next X number of years became adroit at sticking needles into the vertebral artery on purpose. And this spread through the United States, through the Society of Neurological Surgeons, who would meet once at the University of Illinois, and we may put on a demonstration for them, and it spread until it became easier to do it by other techniques. But it was a blessing for a long time, and brought some notoriety to those of us who are involved in it.
Well, I wanted to talk more about vascular surgery and aneurysms and epilepsy surgery and some other topics, and I think we will after the break.
Okay, fine.
We've talked about vertebral angiography, and could you tell us a little bit about your approach to aneurysms? And I know you and Dr. Tinsley successfully obliterated a pericallosal aneurysm in 1946. Must have been when you were relatively early in your residency.
Yes.
But can you tell us, perhaps start with that case?
Well, as I remember it, this was a 16-year-old girl who had had severe migraine headaches for maybe 4 years. Severe migraine headaches meaning strictly unilateral, severe headaches, sometimes accompanied by vomiting and sometimes not. One day she had such a headache, and it was the worst one she had ever had, and she developed some weakness of the opposite side of the body, was hospitalized. Angiography revealed a small aneurysm, and I was Dr. Tinsley's first assistant when we found and clipped the aneurysm. She did very well thereafter, did not have any marked postoperative residues, and thereafter, when we could find aneurysms, we usually tried to obliterate them. One of the problems was that the only clip available was the standard Cushing clip and clip rack, and those clips simply were not big enough. So I induced V. Mueller, who at that time was the principal instrument maker in the Chicago area, to make a clip that was almost twice as long and a clip holder that was appropriate. And we were able to use that with some success, particularly on the posterior communicating aneurysms. From then on, it wasn't until a number of years later that the Mayfield clips were invented, and their use spread very quickly, so that the so-called sugar clip became outmoded, and I was happy to see it go because it was difficult to apply, and the area of application of the clip was always larger than the clip itself, and that was not very smart.
Was it spring-loaded, or was it just a crimp
No,
type?
it's just a crimp type thing. From then on, until I got through with active neurosurgery, I used clips and operated on aneurysms whenever I thought it was feasible. And I remember the first time I did a basilar artery aneurysm, which was very exciting.
Mm-hmm. Mm-hmm.
I remember also the teaching of residents how to use more than one sucker to get the blood when the aneurysm ruptured during the procedure, either on the application of the clip or just before or just after.
At what point do you believe you started using magnification for cases such as this?
Oh,
Loops, I guess.
well, I think I used loops probably within a year or two of going into private practice. The microscope, the first microscope we used was an off-brand type because we couldn't afford one of the expensive ones from Germany. That was about the time that Dr. Salazar came on. Mm-hmm. He was very adroit with his hands, and we bought a modern microscope and used the older one for the laboratory, so that anyone in neurosurgery would take off some time during the time he was in the laboratory to learn how to use the microscope. I can't tell you what year that was.
I think that's jumping ahead to the late 60s or early 70s.
Yeah.
But certainly the demonstration of the vascular lesions with the angiography and the possibility of operating on them and doing so successfully was a major advance at that time.
I think so.
One other area of surgery that was pioneered at the University of Illinois, Chicago at that time was epilepsy surgery.
Yes.
And I've talked to Dr. Gibbs, and he felt that with some urging, he was able to convince Percival Bailey to take the approach. Maybe you can enlighten us a little bit on this era.
Well, the relationship of Fred Gibbs to the neurosurgery department was one of great difficulty. Dr. Oldberg, I think to the end of his career, was never really convinced that the electroencephalogram had any validity for neurosurgeons. he thought that if you were going to get involved with epilepsy surgery, that it might be necessary, but otherwise he really had very little use for it. And it showed an aspect of Dr. Oldberg which has been very curious to me, and that is his tolerance for thoughts and procedures by others in his department, but his intolerance towards them as far as he personally was concerned. He was not interested in epilepsy surgery at all himself, but he was willing to let Dr. Bailey and Dr. Bucy, and later me, work in the field. And he was able to tolerate a number of things like that. He wasn't himself interested in aneurysm surgery, but if he saw that those who were interested were capable of working in the field and that at least some of the results were good, then he was willing to tolerate it. I think to the end of his practice, he would much rather see an air study to diagnose a brain tumor than he would an angiogram. And as far as EEGs in brain tumors were concerned, he had no interest in them at all.
Well, let me show you one picture that I know you've seen, and basically it's taken in the 7th floor of the NPI, Neuropsychiatric Institute, in the old operating room, where you're assisting Percival Bailey with a temporal lobectomy.
Yes.
The year is 1948, and Dr. Gibbs is in the background at the EEG machine. Can you tell me a little bit about Dr. Bailey's surgical technique and how such operations proceeded?
Well, Dr. Bailey was an adequate surgeon. That is, he would set out to do something and he would accomplish it. It would not be done as expeditiously as Dr. Oldberg or Dr. Bucy. He was, however, much more inventive than Dr. Oldberg, and he was not really interested, I think, Dr. Bailey was not, in advancing the technique of neurological surgery so far as making it easier for the surgeon. Now that's not quite accurate perhaps, because he did invent procedures and techniques because the ones that were currently in use were not good enough for him. For instance, he was perhaps the first person to get at an acoustic tumor by making an opening above and below the tentorium at a time when no one else in the world was doing that, and which is commonplace today. And once he had invented a procedure, he really was not interested in doing it 50 times or 100 times or making it infinitely more delicate. He did what he wanted to do. He made a new way of doing something and then turned it over to whoever else was interested. The same thing I think was true with his work with the blood vessel problems in the brain. He felt that if he had a good picture of it, that he could take out an AV malformation. But it was long and tedious, and he simply wasn't interested in developing that type of expertise.
Can you give us the flavor of Dr. Bailey's personality? Can you put into words the kind of person? I understand he was a colorful person, obviously did important investigative work and so forth, but can you tell us about the person a little bit?
it's not easy for me to do that because he was such a multifaceted person. He had so many interests that it was difficult to find one that he wasn't interested in and would not investigate. For instance, as I think you know, he married a lady of Armenian origin who had been a refugee from Turkey, from the Turkish pogroms, and who lived with her uncle in upstate New York, where Dr. Bailey had met her and fell in love with her and ultimately married over Dr. Oldberg's considerable and vociferous objections.
Dr. Cushing's or Dr. Oldberg's objection?
Dr. Cushing's, not Dr. Oldberg.
Right.
So he had many interests in many fields. Foreign languages, he learned primarily when he was in college, and then later on when he made trips to France and to Germany. He was interested in history, in ethnic variations. He became as well versed as anyone that there was in Chicago, I think, in Armenian history. He learned a lot of Armenian language. He spoke French fluently enough that when visitors came here from France, he always entertained them and spoke with them and made them at home. He was interested in mythology and literature, and this becomes all the more striking, it seemed to me, that even now, in view of the fact that he came from a family of German immigrants in southern Illinois, but spent most of his life and education through his own energies and impulses. He was an excellent scholar, knew how to influence younger people into interesting byways, loved to get them introduced to something and then leave them alone. Mm-hmm. And then serve as his counselor and guide, and if it interested him later, he would join in again. He was not someone, I think, to start a new enterprise and then spend most of his life on that one enterprise.
I believe he had quite a sense of humor.
Oh yes, he was a delight to be with, and delighted in telling tales on his associates such as Cushing and some of the other people that he was associated with, especially the beer drinkers, of whom he was one. He's an excellent connoisseur of wines. Introduced us to a wine from North Carolina, made from a small grape which is found only in the southern part of the United States. He also was a connoisseur of good food, and he's a very delightful person to be with.
Now, I believe at this time, Paul Bucy was also an attending man at University of Illinois.
Yes.
Can you?
Dr. Bucy came shortly after Dr. Bailey did. He was one of the best operators, I think, that I have ever encountered. He was not necessarily the most delicate, but he had excellent technique and could outsit almost anybody else who needed to do something which was prolonged. He invented and used things that other people had introduced and had been dropped. He invented new techniques for getting the patient in the right position to operate on the posterior fossa. and showed great resilience in his ability to sit and do something very meticulously, hour after hour. He was an excellent neurosurgeon, quick to learn, quick to tell other people what he thought of them, which was almost always justifiable. And I remember one of his attributes, which I could never understand because I don't know where he got it from, was that he would read the chart of the patient. Something that Dr. Oldberg, I don't know if he refused to do it, but didn't do. Dr. Oldberg depended on word of mouth from the senior resident, and he wanted to know about the patient's age, family, children, occupation, all these things which to the resident had no particular interest for the resident, but Dr. Oldberg wanted to know all these things and retain them. He had certainly the best retentive mind for details of family histories of any person I ever encountered. Dr. Bucy would make rounds infrequently and only for a couple of weeks during the year. Dr. Oldberg was a very jealous man, jealous in the sense of not wishing to have someone associated with him who would challenge him. Dr. Bucy deferred to no one, not even to Dr. Bailey, who was his scientific father. They would argue back and forth, but Dr. Oldberg wouldn't tolerate that. So Dr. Bucy would make rounds for 2 weeks, maybe 3 weeks in the year, and that's all. But when he did, it was a thing to behold because he would look at the chart and read what the intern or resident had written and be critical or praiseworthy, as the case may be, whereas I never saw Dr. Oldberg do that at all. Dr. Oldberg had a fantastic retentive memory for what he was told, but Dr. Bucy read the chart, and if the chart was not up to what it should be, he made it very clear to everybody that he was displeased.
I believe Dr. Bucy had the practice at Chicago Memorial at the same time. Had you gone over there at all?
I went over there only on several occasions to do some percutaneous vertebral angiograms for him, which he was very grateful for and solved his problem on a number of occasions. But no one from the university ever went over to help him.
I see.
Even though he could have used the help, but his being at the University of Illinois was primarily instigated by Dr. Bailey, and he was, from that regard, Dr. Bailey's man. Dr. Bucy and Dr. Oldberg tolerated one another, let's put it that way.
Now, after 1948, you finished your training, and of course you stayed with the university.
Yes.
And I know you were very important in resident training. I wonder if we can talk a bit about your approach to resident training. I know you were intermingled with neurology all the way along. And tell us a little bit about your feelings on resident training.
Well, I really don't know that it could be expressed in any brief manner except to say I think I was more tolerant than Dr. Oldberg was. Tolerant first of neurology, and secondly of the importance of having neurology and neurosurgery taught to the residents simultaneously. Dr. Oldberg came from a school where the trainee had to do his own audiograms and his own visual fields and obviously his own neurological examination, and he required that of all the people who trained under him. He was not, however, particularly tolerant of neurologists in general. I think that probably dates from his time with Dr. Cushing, because I do not recall reading much in the Cushing biographical material of how Cushing got along well or not well with the neurologists. I understand that they they worked together. The neurologists usually the ones who sent patients to him at first, but later the referrals came from other neurosurgeons or from general surgeons. And although Dr. Oldberg was the head of neurology and neurosurgery, and Dr. Roland Mackay was the chief neurologist for a long time under their joint tenure, he made it very clear that he was the boss in neurology as well as neurosurgery. And I think that was somewhat to the detriment for the learning of the students and the neurologists in particular. And I resented that, I must say. I never said anything about it. But when Dr. Garvin became head of neurology and I became surgeon-in-chief, we mutually decided that we would work together and make sure that the neurologists knew what the neurosurgical problems were and that the neurosurgeons had an idea not only of what neurology was like, but also on how to treat a neurologist who, after all, was the source of the neurosurgeon's living in many cases. So I felt that the residents ought to be exposed to neurology and neurosurgery, not only because that was a good way of life, but also because, especially in the 50s, 1950s, 1960s, many of the neurosurgeons went to places in the United States where there was very little neurology, and the neurosurgeon had to be a neurologist as well as neurosurgeon, and I think that that attitude permeated my thinking until I got finished with neurosurgery. And I think even today that a neurosurgeon really needs to know enough neurology to be able to diagnose without a neurologist. And similarly, I think a neurologist has to have some sense of what the neurosurgeon's problems are before he says, well, why don't you operate on this patient? Or, I don't think you could do a good job on this patient. Why don't we just treat him with X-ray? It's a situation in which I think that a mutual agreement and tolerance is necessary.
Speaking about residents, I believe there was one area you were concerned about was that with the shortage of neurosurgical resident numbers, they were being worked too hard and their families were suffering. And you were a proponent of trying to maintain adequate numbers of residents so that the residents wouldn't run into family problems
Yes,
by being overworked.
I made that clear, I think, on a number of occasions to the American Board of Neurological Surgeons. I saw a large number, I thought, of residents in training in Chicago who did not get along well in their families after they finished their training. And I blame that directly on the fact that they didn't spend enough time with their families. And the only way you can spend time with your family is to have somebody who can do the work when you're not in the building. And Dr. Oldberg and the people who preceded him, and Dr. Cushing and Dr. Dandy, simply didn't care, apparently. Now, they didn't say much, but they did not seem to think it was important that, first of all, the neurosurgeons get married. I think Dr. Bailey incurred the, not enmity, but the wrath of Dr. Cushing when he said he wanted to get married. I don't really think that Dr. Cushing was unhappy because the young lady was of Armenian dissent or anything like that. I think he felt that the neurosurgeon in training simply doesn't have enough time for a family and shouldn't have a family. And I couldn't disagree with him more.
Certainly. Let me ask you about some cases. First off, the craniopagus twins, the Brody twins.
Yes.
I believe you were the first neurosurgeon to successfully remove separate a pair of twins. And it leads us to the concept, which very rarely one is in the position of, can you save, do you have to, does one twin become sacrificed to save the other? And it's certainly a position that no one ever wants to be in, but at times I guess neurosurgery can be that way. Can you talk a little bit about that, if you would?
Well, that was a long time ago, and one has to remember what the technical situation is before being critical or non-critical of what the results of an operation are. Just as it became impossible to totally remove a bloody meningioma without having blood transfusion available, so it became clear that technical advances would permit separation of twins that were stuck together at the head, providing the blood supply to the brain could be maintained, and even more important, perhaps, that the blood flow away from the brain be maintained, so that when, as in the case with the Brody twins, there was a single shared superior sagittal sinus, which was getting blood from both sides from two different individuals, it became a problem of which twin gets the vein. Things are different now because we have substitutes for veins. We can do a little bit of an operation for a while and then quit and go back in 2 or 3 times as necessary. We have better blood banks and better anesthesia. But the situation was one which faced me at this time, was what to do about these 2 little kids. We knew that it was possible for these children to grow. There was at that time a pair of Afro-American girls whose parents refused to take the risk of having one child sacrificed, and they lived, they may still be alive for all I know, they lived certainly well into their 20s. The family with which I dealt understood that I could not guarantee anything, and that it was entirely probable that one child would suffer. But on the other hand, it seemed to me that this was no way for people to live, even though there were such people, obviously, who did make a living that way. I mean that literally. They were on exhibition, and that's how they earned their livelihood. And the family understood the situation, and the fact that there was a small chance that both children would survive. There was a good chance that one would survive. And they decided that they would rather have that tried than not. And I was willing to try and spend the time involved. Dr. Oldberg thought that that was not really a wise thing to do, but he didn't say, no, you can't do it in my hospital. And so it was done, and the children were separated. We did not then have artificial duramater, and We didn't have substitute veins that we could use. We didn't have a venous graft possible at that time, all of which can now be done, either from a donor. I would think nowadays, if we really wanted to get such a case operated on again, you might use a parent's vein, saphenous vein, for instance, and prepare it well and substitute that. Certainly it's much easier to replace skull now. It's possible to grow skull by implanting it subcutaneously. But it was an enterprise, one of a number that I've had some hand in.
One other area that I know you felt somewhat strongly about is psychosurgery, and the fact that such operations may have a place, but due to public outcry and so forth are infrequently performed. Could you say a bit about that?
Oh, I'd be very happy to say something about it, because it's still being decried in the press by the psychiatrists who are against it. And I am repeatedly misquoted in their efforts. And the statistics they publish and the background that they give simply is not true. There are people who, for one reason or another, and this is not understood, cannot get along well in the world the way the world is. And if they try, homes are broken, there are battered children, there are battered wives or battered husbands. The social damage from improperly or impossible to treat mental disease is simply enormous. And if the patients are properly selected, it is possible to make these hostile impulses controllable without relying on medication. Now, I'm not implying that it's wrong or improper to give anti-badness medication. That's very useful. But I think the experiences in Illinois and in California of closing down the mental hospitals because you can give medicines, releasing the patients, and then having the patients not take their medicine has produced problems which are certainly much greater from the burden that it puts on society than properly selected operations called psychosurgery. I think there's no doubt that at one time Dr. Freeman, who brought the technique to the United States, was doing more psychosurgery than probably should have been done himself. As you know, he was not a neurosurgeon. He worked with the neurosurgeon, Dr. Watts. They had a number of differences of opinion on how and where and what to do. And nevertheless, there are a number of patients that Drs. Freeman and Watts and others have operated on who are able to make a better life for themselves and their families and for society as a whole by having an operation done to disconnect parts of the brain from one another. Although it was originally true that large procedures on the frontal lobes left some of the patients less than useful citizens, the refinements and extent and degree of operation have made it possible for many people to make good life for themselves. And the opponents who still write today in books for the general public, giving the impression that psychosurgery is a dreadful and terrifying experience, simply are not being fair, not only to the psychosurgical operators, but more importantly to the patients.
Mm-hmm. I know for many years you did abstracts for the yearbook.
Yes.
I believe from 1953 through 85.
Yes.
And certainly had a big part in training a lot of us residents. May I ask you what you feel your most important contributions to neurosurgery might be as you look back on the career?
No, I can't. I think all I can think that I have accomplished is to make people more tolerant of new ideas, to introduce them to them, to take up old ones that have been improperly discarded, and to use whatever is possible to make people happier and have a productive life.
How about some thoughts on where you feel neurosurgery may be going? I mean, here we are in '92. How good can it get? I mean...
Well, I don't think I know that. Unfortunately, this society in which we live has become increasingly violent, and there are increasing numbers of operations and procedures that are being done because of that very violence, not only from gunshot wounds and blunt instruments and automobiles and falls and even so-called games like professional football. I think that more and more we're going to find, I think, that neurosurgeons can do increasing delicate work for things that they can't help, like aneurysms at the base of the brain or tumors at the base of the brain, or finding vascular disease early and clearing out blood vessels which are being stopped up. I would think there will be more and more operations on the blood supply to the brain and to the spinal cord. I would hope that the millennium will come when neurosurgeons and orthopedists will operate simultaneously on the same patient in a way which would enable more people to get the benefits of progress that's already here than even inventing something new. Everybody dreams, I think, of being able to splice in nervous tissue into a damaged spinal cord, or to perhaps find new ways of connecting different parts of the brain to one another so that a damaged part can be bypassed. But those are things for the future that I can't even envisage. I think there's enough available material now to enable neurosurgeons and their colleagues to do even more than they are doing without waiting for the millennium to come.
Well, we've only just touched on some of your contributions and some of your thoughts, and myself and several generations of neurosurgeons owe a debt of gratitude to you for what you've given us, and we thank you for the interview today.
Thank you.